So, hello everyone. My name is Chris Mecoli. I am a rheumatologist at an academic medical center here in the U.S. And here's the pitch. So, rheumatic diseases individually are uncommon, but in aggregate impact about 5% of the U.S. population. The majority of patients who have a rheumatic disease, whether that be rheumatoid arthritis, lupus, myositis, are treated with immune suppressing drugs. This leads to two predictable complications: infection and cancer. Guidelines exist focusing on both of these complications. So for infection, there are guidelines about who we should be vaccinating and who should receive antiviral or antifungal prophylaxis. For cancer, there are guidelines about who is at highest risk of cancer and which cancer types. However, when you actually look at the data that inform these guidelines, much of it is extrapolating data from patients who do not have a rheumatic disease. So they focus on patients who received solid organ transplants, patients with HIV, patients with cancer undergoing chemotherapy, but not actually those with rheumatic diseases. There are some studies, to be fair, that are focused on rheumatic diseases, but they are often focused on a single rheumatic disease or a single drug class and a single data source. So in this kind of idea, this proposed study, we had the opportunity to use the same study design, same definitions, multiple diseases across multiple medication classes and multiple databases. The hopeful outcome of such a study would be to identify modifiable risk factors for these complications, infection and cancer, fill in the existing knowledge gaps of current guidelines, and influence the next iteration of guidelines. My initial idea is to select 4 to 5 rheumatic diseases, so rheumatoid arthritis, lupus, Sjogren's, myositis, and then focus on 3 to 4 strategic infectious outcomes and malignancy, both as a composite outcome as well as for individual cancer types. I imagine that most of the work for this project, in addition to the study design itself, would be creating robust phenotypes for both the rheumatic diseases and the outcomes of interest that would convince a clinical audience the findings are valid and robust.